Bom dia a todos. Começamos mais uma reunião geral do Departamento de Psiquiatria da Faculdade de Medicina da USP. Hoje nós temos a honra de termos aqui o professor Michael Bloch, professor de Yale, para fazer os comentários, o professor Guilherme Polanczyk, professor associado do nosso departamento, ambos especialistas em pesquisa e clínica e tratamento do TDAH, e eu tenho certeza que essa reunião vai ser muito proveitosa. E eu vou apresentar agora ambos em português e depois eu vou dar sequência à reunião em inglês. O título da reunião será Using Meta-Analysis to Guide Assessment and Treatment of ADHD. Quem vai apresentar é o Michael Bloch. Ele é psiquiatra, professor associado do Departamento de Psiquiatria do Child Study Center da Yale University. É diretor do Solnit Training Program e tem se dedicado nos últimos anos aos estudos do transtorno obsessivo compulsivo, a síndrome de Tourette e da Tricotilomania, assim como do TDAH. Para Debatedor, temos o professor Guilherme Polanczyk, professor associado do Departamento de Psiquiatria. Sua linha de pesquisa é voltada para o estudo de transtornos mentais na infância e adolescência, especialmente TDAH, transtornos do neurodesenvolvimento, a partir de estudos clínicos e epidemiológicos e sob uma perspectiva desenvolvimental. Bom, that's a great pleasure to have you here, Dr. Michael, Dr. Guilherme Polanczyk, Dr. Esses, and Dr. Euripitz. So we can start with a talk of the Michael Bloch. Please welcome to your greenhouse here at USP.
Thank you for having me. I just want to make sure everyone can see my screen. Give me the thumbs up if you can see my screen. Okay, that's good. I guess I just wanted to thank you for inviting me today. I'm going to be talking about using meta-analysis to guide the assessment and treatment of ADHD. And I guess I picked this topic for a couple reasons. So I think the first one, just to say, is that I think people were interested in the recent adolescent depression ketamine study, and I wanted to have Jenny Dwyer come talk to you, and I think she's coming June 17th, and she'll really give a great talk on that, and I think she's one of the rising stars in our field, and I just wanted to put in a plug for that talk, and hopefully you'll invite me to attend that talk. And then the second reason was I picked this topic because it really highlights the important collaborations that I've had with trainees from Brazil over the years in my lab, and I've really thankful the collaborations I've had with Euripides and Guilherme, and sort of having wonderful students and residents come over to the lab and work on meta-analysis and on other clinical projects, and that's really been a great asset in my career. And so I just wanted to highlight some of that. And then I think it's also clinically meaningful. So getting the business out of the way, these are the various research support I received. None of them are particularly related to stimulants or ADHD medications, but I'm putting them up here anyway. Most of them are related to treatments for depression and Tourette's and trichotillomania and anxiety and things like that. So who am I and what do I do? So I guess in thinking about this talk, I think it's important to know kind of who I am and what I do at Yale. So the first thing is I'm a busy clinician. So I think like a lot of the doctors I met when I was over in Brazil about 8 or 9 years ago. I have a fairly significant outpatient practice where I see about 140 kids and adults with depression, Tourette syndrome, OCD, ADHD, and I also am very involved in training, so I supervise a bunch of residents. I think Rodolfo told you about the Solnit program. I can guarantee you that everything he said was probably true. Also, I'm involved in running the postdoctoral research training program at the Child Study Center. And then the last thing I do is clinical research in both kids and adults, looking at clinical trials and meta-analysis work. And all the different activities I do really center around the same question. As a clinician, as a teacher of trainees learning psychiatry, and as a researcher, I'm really trying to answer the question, what gives my patient the best chance of getting better? And I'm either trying to figure that out for a specific patient in the clinic, answering a specific question of a resident or another trainee, or trying to answer that with a research question or a meta-analysis. And really, everything I do still integrates around that main question. And what I'm hoping to demonstrate from this talk is just the utility of clinical research and meta-analysis towards improving the care of patients. That I'm going to talk specifically about ADHD, but I think this is generalizable to other areas. And then demonstrate how clinical exposure and teaching also informs and improves clinical research. That really all the research questions that come out of my lab, or at least most of them, really originate from questions that are raised by patients or families that come into the clinic, are raised by trainees who are seeing patients and ask, Dr. Bloch, why are you doing that in this particular patient? And me trying to justify whatever I'm doing and seeing whether I actually can or not, being challenged in that. And then really trying to figure out better treatments in clinical trials when we don't have answers, or doing meta-analyses and systematic reviews to synthesize the literature when we do. So there are really three objectives to the talk. So one is the first one is to demonstrate that your risk of being diagnosed and treated for ADHD is related to your astrological sign. The second one is to understand the efficacies of common treatments for ADHD and examine the effects of dose on the efficacies of stimulants in treating kids with ADHD. And the last is to talk about the efficacy of omega-3 fatty acids in treating ADHD. So the first meta-analysis is on the risk of ADHD and its association with birth date. And so, as you know, ADHD is really associated with three core symptoms: inattention, hyperactivity, and impulsivity. It has to have an onset of age prior to 12, has to cause significant impairment, and has to be involved in multiple settings. ADHD is actually quite heritable. So if you're looking at the relative heritability from twin and molecular studies, ADHD has similar heritability to autism and schizophrenia and bipolar disorders, some of the most heritable psychiatric conditions we have, and much higher than other things I treat, like depression and anxiety. And it has a clear neurobiological marker, which is associated with delayed development of prefrontal brain regions that are involved in cognitive control processes. So I'm going to talk about, the first story actually comes from my family. And so this is a picture of my family. So that's me back when I was younger and had more hair. This is my daughter, Rachel. And this is the twins, Paul and Sam, and my wife, Angie. So that's Paul, who this is going to be about. So Paul is 7 years old now. He's in first grade. He plans to have his own YouTube channel where he's going to be a star. He doesn't know exactly what the content of the YouTube channel is going to be. I think he's going to be very excited when he finds out this lecture was broadcast on YouTube. He likes Legos, racing Matchbox cars, watching Minecraft videos, and he likes to really unbox presents. That was his other stated hobby. And this is a picture back when Paul and Sam were in kindergarten. So they're very into their monster trucks at this point. So this is back when there were 5. And this is actually on the rug in their kindergarten class. And even though this looks like a really happy picture, it was actually a difficult time for Paul. So he was in his kindergarten class, and he actually wouldn't stay on the rug. And when you asked him, like, why don't you want to stay on the rug when the other kids are meeting for story time? He says, like, I'm not good at anything. These other kids are smarter than me. I can't do what they can do. And that's what he said. And honestly, at the time, it was true. I I don't want to be overly harsh, but I think compared to the other kids in the class, he couldn't read as well. He didn't have the same motor skills, and he wasn't able to sit still in story time in class. And so I like, we were worried about it. The school teachers were calling us about it, and I actually talked to my mom, and she's like, "Don't worry about it." I'm like, "This sounds like something I should worry about it. Why shouldn't I worry about it?" She said, "Don't worry, Paul's young." And in fact, he's was quite young for his class. So he was. This is a calendar of 2012, and he was born about a month early with his twin Sam on December 13th, 2012. And she said, like, young kids all the time have trouble in school. Don't worry about it. And I was like, I think he might have ADHD. I think that might be going on. She's like, no, he's going to grow out of it. And so it really brought up my mom's question was the basis for this meta-analysis, which is, and I guess mine, instead of being an anxious parent, I decided to focus my efforts on a meta-analysis to see whether my mother was right. I should have learned by now that your mother's always right, even when she's wrong. So even if the meta-analysis was negative, my mom would still be right. But that's a separate point. So the question is a child's birth date associated with their risk of ADHD, and does the school cutoff date in the area area influence the association? So the cutoff date for schools and grades in Connecticut is January 1st. So my kids were the youngest in their kindergarten class, by far, the twins. If they were born on January 12th, they would have been in pre-K rather than kindergarten. And so this is a meta-analysis that involved 14 studies, involved kids from 9 countries and over 3 million children. And we essentially looked at what are the odds of being diagnosed or treated for ADHD based on the month you were born. And so this is a graph looking at the odds ratio of being diagnosed with ADHD based on the month you were born in school districts that had a December cutoff, so that the cutoff date was January 1st of the year. And you can see the odds ratio of getting diagnosed and treated for ADHD increases with as you get closer to the school cutoff date. So the largest odds ratio are in the youngest kids that are born closer to the cutoff date for the school year. And so the other common cutoff birth date in the States is September 1st, so at the end of August. And this is a graph looking at the odds ratio of being diagnosed or treated for ADHD based on your birth month if the school cutoff date in your area is September 1st. And you see a similar thing, but this time with the risk peaking in August instead of December, of having a much higher rate of being diagnosed and treated for ADHD if you're relatively young for your grade in school. And this is just a graph lining up the two cutoffs, with the December cutoff being in green and the August cutoff being in black. And you can see a fairly similar pattern where the younger you are relative to the grade level, the more likely you are to be diagnosed and treated for ADHD. And this is another way of looking at the same analysis. So the risk of diagnosis and treatment for ADHD if you're born 120 days within 120 days before or 120 days after the school cutoff date. And the odds ratio for both is about 1.4, a little under 1.4. So you were 40% more likely to have a diagnosis or be treated for ADHD if you were born just before the school cutoff date compared to this after. And then lastly, this is sort of another plot looking at the strength of the odds ratio based on how close to the cutoff date you actually are. So going from 100 180 days before or after the cutoff to within 30 days. And you see that the odds ratio is as high as 1.5 in the month before the school cutoff compared to the month after the school cutoff, and the risk of being diagnosed and treated for ADHD, and that's quite profound. The other thing to say is in further analysis, you can see that this risk goes down as kids get older. So this is most likely to occur if you're looking at the kids diagnosed and treated for ADHD at 4 or 5 or 6, and has a smaller effect once you get up into high school years or adulthood, which is not surprising. So the bottom line is month of birth is strongly associated with the risk of being diagnosed and treated for ADHD. It's related to the school entrance cutoff for the particular location. The effect decreases with increasing age, and the effect is fairly substantial. So it's up to a 50% increased risk for the month before versus the month after the school cutoff. But most importantly, it says if you're in Connecticut, where there's a December 31st cutoff, you're most likely to be diagnosed and treated for ADHD if you're a Sagittarius. And if you're in New York with a September 1st cutoff, you're most likely to be diagnosed or treated with ADHD if you're a Leo. I would say also this has significant implications for biological studies of children at risk for ADHD, because it may not be chronological age that's necessarily the most important factor to control for, but it may actually be relative school age or what your school grade is that may be more important for diagnosis of ADHD symptoms rather than your actual chronological age. It also has significant implications for public policy and early education, because as parents, the solution's obvious to this. When Paul's not ready to go to first grade in a new school, you have him repeat kindergarten with Sam in the school, and he's doing great now, and he may have been doing great anyway, but that essentially solved the issues he was having in school instantaneously. That being said, I estimate it cost us $36,000 to do that, and most families don't have $36,000 lying around to put in on their kids' development, and we need to be able to do that as a society. So I guess so that's the first talk. The second meta-analysis came from parents I see at the clinic, and I'm sure I hope child psychiatrists in Brazil have the same experience I do when treating ADHD or depression or OCD in kids, where a parent will come in and you'll say, and you want to raise the dose of the stimulant medication, and the mom or dad will say, well, 36 milligrams of Concerta seems really high. Isn't 18 enough? And you see the same thing with 54 milligrams or Adderall or Vyvanse or all the stimulant medications. Essentially, there's this real hesitance in parents and a need for justification of why you're increasing the dose in their kid when their child's may already be doing better on the medication. So this is a meta-analysis about stimulant dosing in childhood ADHD. It's actually done with Luis, that's hopefully in the audience somewhere, who's a extremely talented med student, now postdoc, who came and worked in the lab for a year, who's been a tremendous asset to my research, and is a burgeoning star in child psychiatry and meta-analysis. And essentially, for ADHD treatment, there are really two games in town medication-wise, methylphenidate derivatives and amphetamine derivatives. There's some differences in the medications based on pharmacokinetics or immediate release versus controlled release formulations, but they all share a fairly similar mechanism of action, and they're divided in these two families, but there are a ton of different medications. So I like to put up this chart of that I give to the child fellows at Yale of all the different methylphenidate medications that are currently available in the U.S. and so there are a lot of them. So it's kind of overwhelming. They're probably, I haven't counted the individual pills, but there are probably 40 or 50 different pills on this thing of just methylphenidate derivatives. And so there's long-acting ones. They're now long-acting delayed release medications, and they're short-acting medications. But they definitely, they generally have a different duration of action and sometimes onset of action. And that's the main difference between the medicines, but they all have the same active ingredients. Very similar stuff with the amphetamine derivatives, a lot of different long-acting and short-acting medications. There are a few non-stimulants on the market, but there are a ton of medications, and at least all the data kind of shows that they work very similarly more than differently, and in terms of efficacy, and that they're really these two families of methylphenidate and amphetamine derivatives. So how well do stimulants actually work for ADHD? So this is my absolute favorite trial of all time. So this is the multimodal treatment for ADHD, and this is more than 2 decades old, and I still think it's, to me, the most influential study in child psychiatry. So it was funded by the NIH, involved around 580 children who were aged 7 to 10 with ADHD combined type. They were randomized to receive either medication management, which was just evidence-based treatment with immediate release methylphenidate. They were given a behavioral treatment program, which was quite intense. So I would say, I like to say it's like it's like putting on steroids, the best behavioral treatment I could possibly give to any kid who walked into the clinic. So the behavioral treatment involved parent management training, which had 35 sessions. It had a ADHD child-focused summer camp where they essentially went for 8 weeks during the weekdays to a summer camp where they learned skills to help manage their ADHD, the kids. There was a school-based intervention that involved 16 biweekly teacher sessions, and also involved a paraprofessional coming into the school. And the other thing that was amazing about this behavioral treatment was they actually had the same clinicians doing a lot of the different interventions, so people would follow the kid across interventions. So then there was either combined treatment with both, or they were randomized to treatment in the community. So there was no placebo arm, and they did one of these treatments for 14 months. And I think the results were really profound and surprised a lot of people in the field. So if you look at the outcomes, essentially the big difference over these 14 months of treatment was whether you were in the medication management arm or not. So there was the medication management and the combined treatment arm had similar benefits in terms of ADHD symptoms, and that was much better than either the behavioral treatment alone, which again I would say was behavioral treatment on steroids, and was better than community treatment. And within the community treatment, the kids who received stimulant medications had a better outcome than the ones that didn't. And the vast majority of kids receiving community treatment got stimulant medications. So this was really profound. So this is why stimulant medications are the treatment of choice for ADHD, because over the long run of studies, they work significantly better than even the best behavioral treatment we could possibly offer our patients in terms of reducing ADHD symptoms. Now, why would the medication management arm work better than the community treatment arm, even when the vast majority of kids in the community treatment arm receive stimulants? And and so they did substantially better, about 50% better in terms of their reduction in ADHD symptoms if they were in the medication management arm. And the likely explanation for this was at least hypothesized to be differences in dosing of the stimulants. So when children were assigned to the med management condition, they received an average methylphenidate dose of somewhere between 31 and 34 milligrams a day. Whereas if they were in the community treatment arm, they only received 22 milligrams a day. So the thoughts that the higher doses of the stimulants may have led to the improved efficacy. And so the big question is, does dose escalation of stimulants actually have that big of an effect? Another study recently that suggested that this might be important was actually a study that was just published in JCAP in this past year by Blader et al. That essentially looked at comorbid aggression symptoms in kids with ADHD who had previously not responded to stimulant treatment. So in the first three, it was essentially a trial to look at what was better to control aggression: Risperdal, Depakote, or placebo. The kids were started on stimulant medication. They'd all previously not responded and were optimized in dose over the first 3 weeks. And those who had not responded to the stimulant medication were then participating in the randomized control trial. So they had 150 kids that they enrolled in the initial study, and 63% of the kids who were in the initial 63% of the kids responded in the initial open stimulant treatment arm. That is, when you optimize the stimulant medication, the kids with ADHD and aggression, their level of aggression was no longer significant enough that they could participate in the trial. So they didn't really find any difference between the medications, but it was essentially a failed trial because they couldn't, because the thing they learned was that if you optimize the stimulants, most of these kids will respond to treatment. So we really wanted to look at this dose response meta-analysis in stimulants closer. And so we looked for randomized placebo-controlled trials of stimulants in childhood ADHD. We found 67 randomized controlled trials of over 8,000 school-age children and adolescents with ADHD. And we looked at how were the efficacy and tolerability of medications affected by stimulant dose. And so this is the first take-home slide from the trial, and this is the relative dose of stimulant medications in terms of methylphenidate equivalents on the x-axis, and on the y-axis is improvement in ADHD symptoms in terms of effect size. And the big thing you notice across studies is that there's a significant increase in efficacy of stimulant medications for ADHD as you increase the dose. The other thing is that the curve really starts to flatten out in studies around 30 to 40 milligrams. The next thing we looked at in these studies was, is there a difference based on fixed dose versus flexible dose studies? So fixed dose studies, which is the curve seen here in blue, essentially you're randomized to receive a specific dose, and you either take that dose or you drop out from the study. So essentially you can't adjust the dose based on tolerability. In a flexible dose study, it's essentially a dosing study where that's the maximum dose you can take, and if the child has trouble tolerating the medicine, you can then go down to a lower dose. And the big thing is, when you separate the fixed dose versus flexible dose studies, the fixed dose studies have essentially a curve that flattens out again around 30 milligrams, so that almost no matter what, it makes sense to increase the dose up to 30 milligrams on average. And then if you're forced to keep going up, it still has some benefits from 30 to 60 milliequivalents of methylphenidate, but it's much less. Whereas if you're looking at a flexible dose study that's more similar to what is done clinically, where you could go down on the dose if they have side effects, it has a fairly linear curve where you're more likely to get greater benefit at the higher doses of medications. The other thing we looked at is just the families of the medications, and amphetamines are in red, and methylphenidate derivatives are in green. And the amphetamine study showed a greater dose efficacy curve at the higher doses compared to methylphenidate, was the other thing that we found. Just looking at this again, so these are multivariate analyses. So now the graphs are divided between fixed dose studies, which are again in blue, and flexible dose studies, which are in orange. And these are only the methylphenidate studies and only the amphetamine studies. Similarly, in looking at amphetamine versus methylphenidate, these are stratified by the fixed dose studies versus the flexible dose studies. And you see the same kind of relationship between fixed and flexible dose studies across the medicine, and with amphetamine versus methylphenidate in fixed dose studies and flexible dose studies. Essentially, flexible dose studies have a more linear dose response curve, which is not surprising because you don't have as many people dropping out at the higher doses because they can go down on the dose due to tolerability. And again, you see that amphetamines tended to have a greater dose response relationship within the dose range than methylphenidate. Other things, because how well the medicine works isn't the only issue, is what's the tolerability of medications? What's the likelihood of people dropping out due to side effects? And not shockingly, as you increase the dose of the medications, stimulant medications, more kids are likely to drop out due to side effects. This is true more in the fixed dose studies in blue compared to the flexible dose studies, which is again not surprising. Less kids are going to drop out at higher doses if you can adjust the doses down. And it was higher in amphetamine studies compared to methylphenidate studies. And again, when you do multivariate analysis and you stratify it by both dosing strategy and agent, you see this you see that the main effects of tolerability, the main effects of reduced tolerability associated with dose for both agents are seen in the fixed dose trials when you can't adjust the dose down when people are having side effects, and not nearly as much in the flexible dose studies. And then again, the tolerability, the worst tolerability with increased dose was seen in amphetamine. The last thing, and as important as the efficacy analysis, is just talking about accessibility. How likely were patients to drop out from treatment? And so the first finding is that the higher dose of stimulant you went on in trials, the less likely you were due to drop out for any reason in the trials. So the acceptability of stimulant medications was actually higher when you used a higher dose. That's probably because they work better, and how much they work better outweighs the tolerability for most patients. Again, not surprisingly, in the flexible dose studies, you saw a greater increase in acceptability as you got to higher doses, and the same thing was true with methylphenidate, that you saw greater acceptability at higher doses. And it was just to say that again, the major difference in this was in the flexible dose trials versus the fixed dose trials, and where the acceptability was higher at the higher doses, and the particular agent didn't make a huge difference once you stratified for design. So what's the bottom line? So the first one is that there are significant benefits to higher doses of stimulant medications. And it really makes sense in the vast majority of cases to try to optimize the dose. That it seems like higher doses of stimulants are not only have greater efficacy, they also have greater acceptability if you're willing to counsel the family and potentially go down on the medication if the kids are having significant side effects, which in my experience are not eating and not sleeping. And it really suggests that, like the MTA study, that prescribers in the community should be using higher doses of stimulant medication than they're currently using in a lot of cases. That I think this is by far the most common error that I see in my sort of tertiary clinic, where we get referrals for treatment refractory OCD, ADHD or aggression, is that the prescriber hasn't maximize the stimulant medication or manage the side effects that it's causing effectively. And so the kid can't be on a high enough dose. And I think this is a really important thing. And that I see tons of kids on the inpatient unit at Yale hospitalized with aggression and ADHD, and almost all of them are on, Risperdal or Abilify or lithium or Depakote, like the Blader study did, and very few of them are on maximal dose stimulants. And it really highlights the importance of doing that, because it seems to work really well. So the third one. So another question that I often get asked by the same parents, often the same ones who are hesitant about giving their kids psychostimulant medications or raising the dose, is, should I give my child omega-3 fatty acids for ADHD? I'm not sure this is as common a question in Brazil as it is in the US, but I would say this is at least a question I get every month in my practice, is about omega-3s and ADHD. And I actually first heard this question back when I was just starting out at faculty at Yale. And I remember I was really quite skeptical. I'm like, hopefully you can tell from this lecture that I'm a pretty big psychopharm guy. I think the medications work really well for ADHD. I was actually quite a bit of a skeptic of omega-3 fatty acids. It was around the time where we were in the process of publishing a meta-analysis looking at omega-3 fatty acids for the treatment of depression in molecular psychiatry, which essentially found that omega-3s demonstrated small, non-significant benefit for the treatment of major depressive disorder. Publication bias likely accounted for all the treatment benefits that are observed in the literature. And that basically the effects were zero if you adjusted for publication bias. And I don't think by the time we actually got this out in print, it wasn't that much of a revelation anymore, because someone, Appleton, published a similar meta-analysis looking at depressive symptoms, not major depressive disorder. And this was the main funnel plot from the paper, which showed a significant benefit of omega-3 fatty acids for depression symptoms, actually a little over 0.1 in terms of effect size. That was small but was significant. But the other thing that they found in the meta-analysis was this, which if people remember the meta-analysis course I taught way back when, this is a funnel plot. And this is a plot used in the meta-analysis to look at publication bias. And the main idea is that omega-3 fatty acids should have the same underlying effect, the same underlying measured efficacy, no matter how big or small the trial is. That larger trials, so this is basically looking at the inverse of error in the study. So you can essentially think as larger studies are towards the top, should have very little variation or error in terms of the estimate. If you do a study in 1,000 people, it's going to give you a closer estimate of effect than if you have 10 people. And that this should have a symmetric pattern like a funnel. And so essentially these, so this graph should be symmetric. And what's happening here is it's missing all the smaller studies. So they're not published in the literature. It's missing all the smaller studies that didn't show a benefit of omega-3 fatty acids. So it's suggesting that there were publication bias in the literature, that there was selective publications of the smaller studies based on whether or not it had a significant treatment effect. And so it's really suggesting that there may not be an effect in depression. And this is just forest plot looking at the efficacy of common treatments for depression. So antidepressant medications that may have an effect size of about 0.3, CBT that may be closer to 0.7, exercise around 1, and then it compares it to the omega-3 fatty acid studies that is small to none, based on whether you factor in publication bias or not. So I was really skeptical because I thought the data that actually worked for depression was quite poor. But my patients had the question, ADHD is not depression, so it could theoretically work for ADHD and not depression, and this is an important thing to know. So why might omega-3 fatty acids work for depression? So the first thing is that they can't be synthesized by the human body, and they're often deficient in the diet. So you need to get this. You need to get this through the diet or supplementation. They have anti-inflammatory effects. They've been shown to affect neurotransmitter signaling by changing the fluidity of cell membranes. There's actually also evidence that omega-3 fatty acid supplementation may improve executive function, which again is, as we talked about earlier, is related to the neuropsychology of ADHD. There's also evidence that there might be something going on in terms of omega-3 levels in cases of ADHD. So there are meta-analyses, this one showing that children with ADHD have higher omega-6 to omega-3 fatty acid ratio in the blood compared to control subjects. And it's quite significant, and it's found across studies. They have lower levels of kids with ADHD have lower levels of omega-3 fatty acids, again, fairly consistent and significant across studies. Also of specific omega-3 fatty acids like EPA or DHA. There's also some evidence, again, that omega-3 fatty acid supplementation may improve executive functioning. So executive functioning are sort of cognitive abilities that are regulated by the frontal cortex, that are commonly associated with ADHD, attention, shifting between tasks, response inhibition, planning. If you look at questionnaires looking at executive functioning, parent-rated executive functioning in kids with depression, you actually show that even though the omega-3 supplements really didn't have much of an effect for the depressive symptoms, they actually seem to improve executive functioning as a secondary outcome. So the big question is, are omega-3 fatty acids effective for treating ADHD? So this was a meta-analysis I did with a student from Turkey, I believe, about 8 or 9 years ago. It was a meta-analysis looking at 10 trials involving 700 kids with ADHD, and essentially is randomized placebo-controlled trials comparing omega-3 fatty acid supplementation compared to placebo, and the primary outcome was just change in ADHD symptoms. And the major thing we found, quite to my surprise, was that there was actually significant evidence in the literature that omega-3 fatty acid supplementation was modestly effective for ADHD. So it has an effect size of around 0.3, and it was fairly consistent across studies. So what was interesting is that basically only one of these studies actually showed a significant benefit of omega-3s across all the studies, but they were actually showing quite consistent results, which were quite consistent with it having a small beneficial effect. There was no evidence in publication bias within these studies. The funnel plot's symmetrical. The other thing we found was that that the measured efficacy of omega-3 supplementation in reducing ADHD symptoms was correlated with the dose of EPA in the supplementation. So that the greater the dose of EPA you had in the omega-3 supplementation, the better they worked for ADHD. And for this reason, I generally recommend that people take at least 500 milligrams of EPA in any supplement they give their kids in terms of omega-3s. It still doesn't answer the question that's probably most as important as a clinician. How well do these omega-3 fatty acids compare to other medication options for ADHD? And again, as we talked about before, the first line treatment for ADHD are stimulant medications, the methylphenidate derivatives, and the amphetamine derivatives. And we generally use them first because they work better and faster than the non-stimulant medications for ADHD that are also quite effective. Again, back to this, there's in the US, there's this huge illusion of choice in terms of different ADHD medications, but there are essentially two types of ADHD medications, and the formulations differ slightly in pharmacokinetics. And the real reason we have 100 different medications for ADHD and doses and stuff is mainly to increase the patent length on the, or to have new patents for the medications so that the pharmaceutical companies can make money on medications that are helpful for ADHD. Again, these are the amphetamine derivatives. And really, when you look at this, so this is a meta-analysis that was published a few years ago. This was a network meta-analysis, and essentially the blue boxes are looking at the risk ratio of response in the treatment, so of whatever the row is compared to the column. So you'd read this as basically methylphenidate has you're 5 times as likely to respond to methylphenidate as you are to placebo in terms of ADHD treatment, and on the red is risk ratio of dropout. And the big thing you see from this meta-analysis is first all the different pharmacological agents we have are quite effective for ADHD. So at worst, the risk ratio is 3. And then the other thing is the stimulants work significantly better than the non-stimulant medications for ADHD. Not going to go through it too much, but if you look at meta-analyses in adult ADHD, you basically see the same thing, that the stimulant medications for ADHD have a lower number needed to treat, meaning they're more effective, so around 2 to 3 for adult ADHD compared to the non-stimulant medications, which have number needed to treat around 5. So again, stimulants are more effective than non-stimulants. And really, in terms of the efficacy of stimulants for ADHD, there's not great evidence that there's difference between classes or short-acting versus long-acting stimulants. Some data suggests that the amphetamine derivatives may be slightly more effective. The big thing is that they work fast, so I can see the benefits of stimulant medications in my ADHD patients overnight, whereas the non-stimulant medications only work, probably have about half the likelihood of response, and then they also take much longer to work. So they're working over the course of, months rather than days or weeks as the stimulant medications, and that, at least to me, makes the stimulant medications much more preferable. So this is another meta-analysis that was recently published by Sam Portese, looking at the relative effect sizes of stimulant medication for kids with ADHD on clinicians' rating of ADHD severity, and shows very similar trends. And if you were going to take our omega-3 fatty acid results and put them in this meta-analysis, you would see a much smaller effect of the omega-3s. So it's about a third of what you see for the stimulant medications, and about half of what you would see for even the lowest point estimates of benefit for the non-stimulant ADHD medications. So how do I advise families with regard to omega-3 fatty acid supplementation for ADHD? So there's definitely some evidence that omega-3 fatty acids are beneficial for ADHD. I must say, even though there's no evidence of publication bias in the literature, I'd still, based on the larger omega-3 literature, I'm still a little worried, even if my funnel plots don't show anything. The omega-3s have fewer side effects and are probably better tolerated than the prescription medication. I would generally say take up formulation with a greater dose of EPA. The big thing to say is that I really discourage using the omega-3s as a substitute for other evidence-based treatments for ADHD, specifically stimulant medication. Stimulants work much better and much faster than omega-3 fatty acids. And I think ADHD can have serious long-term impacts on kids' social development, their academic achievement, even their health in general. So we know that ADHD is associated with a higher risk of dropping out from school, a higher risk of getting into accidents, whether it be broken bones or traffic accidents when you get older. They're associated with higher rates of ADHD is associated with a higher rate of incarceration across the world. And even higher rates of divorce. Also, when you're an adult, it's associated with decreased amount of earnings related to your education level, and then also increasing job turnover. And then you actually see most of those things get better in epidemiologic studies when you compare the same individuals on and off stimulants. So these medications really have profound effects on people's lives. And I don't really agree with the rationale, hey, you can see if omega-3 fatty acids work enough and then you can try stimulants, because it'll often take you 6 months to know the answer. And even when kids get a little better on the omega-3 fatty acids, you can often get a much, much more better on the stimulant medication. So generally, delaying stimulant medications to try omega-3 fatty acids or behavioral therapy for that matter is generally something I do not recommend to families and kids who have significant ADHD symptoms. The last thing to say is I think it's also important to be mindful of the psychological effects of giving more medications, of giving more pills. I sort of think about the younger kids that I see, and I think there's a general, at that developmental level, you can think of, if I take one pill for this thing, it's a minor problem, or maybe it's a medium-sized problem. And if I take 5 pills, it must be a major problem. And I just really worry about parents who give their kids like 6 different supplements for their different psychiatric conditions, and how that's making the kid feel in terms of taking a lot of medications. And I think kids should only be on medications if they're significantly helping them. So the challenges for nutritional research in ADHD, I think the first one that's really important to talk about in terms of omega-3s is just potential confounding by socioeconomic status, geographic region, and culture. I really wonder how much of these epidemiologic data about omega-3 fatty acid level differences between ADHD and controls, or depression and controls, is really related to things like socioeconomic status, and then also where people are living, because I think certainly in North America, eating more omega-3 fatty acids is associated with having more money and more disposable income to spend on food, and then this would be clearly related to ADHD diagnosis. Other issues in omega-3 fatty acid research and nutritional supplement research is just the consistency of the product. When you start seeing very discrepant results in studies of over-the-counter supplements, you wonder whether people are using the same product between different studies, even if they're getting it from the same manufacturer, since it's not as nearly as tightly controlled as a prescription medication. The other issues with omega-3 fatty acids and nutritional research in general is just blinding. It's very hard to tell how well a trial is blinded based on the manuscript. I've never been able to do it. Do the pills really look the same, smell the same, taste the same? Well, I can tell you that the early studies of omega-3 fatty acids certainly had a fishy aftertaste. It's gotten much better in the later studies, but you wonder how much of an issue that is. And you really have no way of looking at that in the published studies. Just inadequate funding of the research, and since it's not really driven by the same kind of profit motivation as the pharmaceutical studies and the patent protection, that you get studies with much smaller sample size that are associated with also higher risk of publication bias, because there aren't the same reporting requirements of trials, at least when this research started, and that could really affect the point estimates in the literature. And I ended early, but I think your attention span is probably waning at the moment. But I guess I just really want to thank Euripides and Guilherme and Rodolfo for inviting me, and then also thank the wonderful students from Brazil who've been working in my lab that really contributed to a lot of this research. Luis, Pedro, the Eduardos, really thank you. That a lot of the research and my successes have been related to these people coming in the lab, and I really appreciate them, and I think the world of them. So thank you.
Dear Dr. Michael, thank you. Thanks a lot. I just received a message from our secretary. She said that she will have fatty acids for the rest of her life. So so far,
hopefully she's organized. I hope she doesn't have ADHD.
I hope so.
That would be bad.
So, thank you so much for this wonderful presentation. Guilherme, please make your comments and say whatever you want.
Thank you. Good morning. Thank you for inviting me. Thank you, Michael, for joining us this morning and for sharing with us your studies. It's always a pleasure to listen to you and to learn from your studies. I had the chance to interact with Michael several times in several contexts over the past years, and Michael has always been a great collaborator for our center. So as he mentioned, he received several of our trainees, and it's very, very nice, and it's a pleasure for us to learn that they have contributed to your work, and certainly for their careers, the experience with you has been very, very important. So thank you very much for this long collaboration, and we hope that in the near future our residents are able to visit again. So I'll make a few general comments, and I'm sure our audience has lots of questions to you, so we interact with them after that. The first point I would like to emphasize is probably your first or second or third slide, is the integration that you usually does in terms of research and clinical work. So we believe this is really, really important. And as you mentioned, certainly one improves the other. Research improves our clinical work, and the clinical work, as we are tuned to the needs of our patients, will make relevant questions to be answered by research projects. This is very much how we think and how we train our residents, integrating the evidence-based medicine in their day-to-day practice. And definitely your work reflects that your clinical expertise and how sensible you are to the needs of your patients. So meta-analysis is really a powerful research strategy, and when it aggregates well-conducted original studies with enough statistical power, and when they are conducted with the methodological rigor that Michael teaches us, so he has a course in our PhD project, and it's a very well-attended course and really important. So when we have these ingredients, the results can actually support clinical practices. And I think this is really, really important. A part of these 3 studies that Michael showed us, he has other meta-analyses on ADHD, which were really important. So I think there is one on comorbid disorders with Lemann. You have an important meta-analysis on the risk of tics with stimulants, risk of anxiety with stimulants. So Michael really have contributed and still are contributing and will be contributing to the field of ADHD. And these meta-analyses are really, really important to the field. In fact, the field of ADHD has a very rich literature. And recently we have, along with other 79 authors from 27 countries, we have contributed to the World Federation of ADHD International Consensus. It was led by Steve Farron and published in Neuroscience and Biobehavioral Reviews. And in this consensus, we have 208 evidence-based conclusions about the disorder, which is really impressive. ADHD is a very well-studied disorder. We know a lot about it, from epidemiological studies to genetics, biological treatment. So we really know a lot about ADHD. We know that ADHD costs hundreds of billions of dollars each year to the countries. There are several medications that are safe, they are effective, not only for treating the symptoms, but also for preventing many functional outcomes, which are really, really important. We have non-medication treatments that are also effective, less effective than medications. So we really know a lot. Of course, there are important gaps in the literature, and Michael is addressing several of them. And there are also gaps in terms of services and in terms of delivering treatments to those who need treatment. In our country, for example, a few years ago, we conducted a meta-analysis, a systematic review actually, and in some studies, in some community studies, none of those diagnosed with ADHD were receiving treatment. Recently, in our INPD in São Paulo and Porto Alegre, 20% of those with any diagnosis, not only ADHD, but any diagnosis, were receiving treatment in the community. So we have a really huge gap, which of course we have to address, and also we have to address the important clinical questions to when these children are receiving treatment, so we make sure that they are receiving the best treatment, the more adequate way of assessing them. And these studies that Michael just showed us, so they have really clear and direct implications for the care of these children. So first, the first study has an important aspect that makes clinicians to make sure that they assess differential diagnosis and consider normative development as a differential diagnosis for ADHD, especially in these young children. And the second, higher doses, higher benefits, but of course with a flexible dosing regime, which means we have to follow up these children really closely. And one important point, Michael, that you made was that monotherapy must be pursued, and combining other medications when we have low doses or not all the benefits that stimulants can give it to us, not only for ADHD symptoms, but for irritability or associated symptoms. So it is really important to that. So these are general comments from your talk, and I'm sure we have several questions and comments from the audience. Again, Michael, thank you very much for being here and for sharing with us your thoughts.
And I guess one of the reasons I think I love the Brazilian students and trainees so much in the lab, I think is probably related to the integration of academic research with the clinical care that I think most people in Brazil still have in their ongoing careers, which I think is different than a lot of the academics in the United States. And I think that's often made the trainees who come in who have been quite facile, both with numbers and with sort of clinical issues. So they come in with good questions, then also have a lot of the sort of analytic skills to start to look at it. Also, maybe that you guys are just doing a good job sending students to me. That's probably selection bias is probably the number one reason. But
great, Professor Euripides, Professor Orestes, would you like to comment something?
Can I make a quick comment, Orestes? So I'm also like to thank you, Michael, not only for giving this wonderful lecture, but also for training several of our students and giving a course in our post-graduation program as well. And I agree with Guilherme when I believe you developed a very good way to raise very important questions and bring very relevant answers to our field. And I think some way is part of it is the integration of clinical work with research questions, as Guilherme mentioned. But also, I think you have foreseen you anticipated the importance of conducting very good meta-analytical studies to solve those questions, and you became an expert in this area, so you know very well the limitations, and you are teaching us how to overcome some of the limitations of the method, but more than that, bringing very relevant questions, answering very relevant questions, as you did today. So I'm coming back to my clinical practice today with some new information. I have learned about omega-3 in ADHD, for instance, but it's nice for me to know more about having you talking about that based on your meta-analysis. And in this regard, you are a reference today, and I feel more comfortable in giving omega-3 to my patients after reading one of your papers in this field. So I think that's a great contribution. I'm the kind of that clinician that always looking for the smaller doses and go very slowly to treat my patients in general. So I'm learning that in ADHD probably you have to go quicker and offer a higher dose, probably fixed higher dose would be better even to diminish dropouts. But mostly to get a better efficacy of this medication on this disorder. So it's wonderful that you have answered these questions based on very, very well done studies. Just to make one question at least for this incredible conference. Michael, the first question, the relevant question we raised today was related to having early diagnosis, being younger in the school age is associated to ADHD, right? So my question is, so if this is true, being younger based on the school age is a risk factor, right, for you to have ADHD. So in the long term, 10 years later, this tendency to be this association is maintained.
So we don't have 100% great data on it. It's clear that the association gets less as you go farther along, and that the diagnosis will stick with kids, but it's unclear how much the treatment will persist. Like, are they still being treated for age? So my sense is the effects probably get much less over the longer term. The other thing that's really difficult, at least in the United States, is that there's, again, this issue of the association of class and wealth with holding kids back in school is a significant confound. So, like, my kids who were born in December, the twins are actually at lower risk because they're now a year, they're held back and they're a year older. And so I wonder how much the effect would be affected by just socioeconomic status. My sense is the effect would be larger in the younger, poorer kids and smaller in the richer kids, for the lack of a better term. And I think all that comes about. I guess the other thing, am I allowed to comment on another thing you said? Because I think I have I guess the other thing is just to talk about the dosing of stimulant medication. So I dose stimulant medications completely different than every other medicine in psychiatry. So I really have a distinction that essentially I try to teach the residents, and I talk to the parents about going up until you have side effects on the medicine. Because I think my experience is that community physicians have left a lot of the benefits of the stimulants on the table because they really work so much better than almost any other medicine we have in psychiatry, and how quickly that we work and how much the effect size is. So usually I'm going up to the point that they have side effects and then backing back down. Just telling the parents, when your kid can't sleep at night, give me a call and I'll reduce the dose, or we'll see what else we can do. And that oftentimes you can get, parents are perfectly, at least in my experience, perfectly okay with having their kid have trouble sleeping for a couple of days if it means you're going to get a better handle on their ADHD symptoms. And I think that's not true for like SSRIs and even antipsychotics, where the dose response relationship is much smaller. And then also the other thing about stimulants is you can see the effects so quickly. So you can actually make the decision about dosing with information, whereas in an SSRI, you have to make the decision about side effects before you know whether you're going to keep the person on a dose because of side effects when you don't know how well it's going to work. Because OCD, it takes 2 months to figure that out. Whereas you can give them sexual dysfunction in a day with an SSRI, maybe 2.
Thank you.
I may make a few comments, Rodolfo, please. Well, first of all, thank you very much, Michael, for visiting our department and our institute, although virtually, and interacting with us today. It's really important to have you and your insight. Congratulations for your excellent talk. Really robust and convincing data. And I'm not in the field of child psychiatry, and I really learned a lot with your presentation. Thank you. As I said, I'm not a child psychiatrist. I'm the other end of this continuum. I'm an old age psychiatrist. And as such, of course, I've been thinking about the implications of what we are saying to my practice and this field of knowledge, particularly because patients with ADHD you have, of course, adults in adult life, and some of these guys are getting older and reaching late life. So what's going to happen with this patient with previous history of ADHD? My question would be if we should be concerned about providing some neuroprotection in addition to symptomatic. As you said, omega, I was intrigued because I wasn't expecting a symptomatic effect of omega, which is very interesting, although it's much smaller than medication, psychostimulants. But there is something there indeed. Would you think, in addition to this small symptomatic effect, would get something else, considering neuroprotection or perhaps preventing some kind of damage due to long-term disease during several decades or several years? Could you please comment about that? And if you what you think about the association between ADHD and increased risk of dementia? I think some of these associations have been ruled out. For instance, there seems not to be association with Alzheimer's disease, but perhaps there might be some associations with frontotemporal dementia, and a recent study showing associations with Lewy body dementia. So if indeed there is such association, should we also consider some interventions to deliver neuroprotection or maybe neurorestorative effects in addition to symptomatic effects?
So I guess I have a bunch of things. So certainly dementia is not my area of expertise. So I think I'll try to stay a little away from that. Other than to say, I would think I don't know that literature well. I would think one important factor in risk of dementia would just be all the things that poorly treated ADHD patients are doing as adults that would put them at risk factors for poor medical outcomes and dementia and a bunch of other things. And that at least in the United States, it sounds like in Brazil, there are two issues. One is that most of the kids who have ADHD can't get treatment. In the US, that's probably much less of an issue in terms of the kids getting treatment for ADHD. They're probably not getting the best treatment, and it could be enhanced, but most of them are getting some treatment. The big issues are that when kids become adults, that they're stopping treatment. So that whereas you look at the long term in the MTA study where the kids responded fantastically to the stimulant medication over the short term, like 10% of the kids as adults were actually on medication for ADHD. And that essentially when kids become adults, almost all of them go off the stimulant medications. I think for various reasons, one of which is that the adult prescribers aren't comfortable using them in the States or are as familiar with ADHD. Then you have to deal with all these bad outcomes like substance use, incarceration, traffic accidents, getting fired at work. So I think one thing in the U.S. is the undertreatment of adults with ADHD is sort of a big issue that needs to be looked at. There's also the other side of it where there's a significant abuse potential with the medicine, and they're being maybe prescribed for the wrong people, and that deserves to be said too. But I guess there's really a big issue on just treating adulthood ADHD and managing those symptoms, and then I guess just in terms of neuroprotection and prevention. I mean, those are really large studies that I don't have the answer to. I think they'd be worth looking at, but we're probably looking at if you're looking at omega-3s, you're probably looking at a small effect of supplementation that's confounded by, socioeconomic status, culture, where you're living, and it would be. It's an important question, but it would be very hard to disentangle all that. And I don't know the answer. It's an important question.
Thank you.
Great, Michael. I have a question too for you regarding a possible suicidal risk associated with introduction of psychostimulants medications in these kids. I know I was reading yesterday a recent paper on JAMA saying the opposite, a possible protection in suicidal risk after 90 days of the introduction. Do you have any experience or tip regarding this introduction to reduce the possible increase of suicidal risk?
I think the first thing to say is I would not be surprised in a long-term reduction in attempted and completed suicides in association with stimulants, especially in younger kids, because so much about suicide attempts are related to impulsivity and spur of the moment decision making, also substance use, and that stimulants in general are going to be very it will be very effective at reducing impulsivity and have been shown to decrease long-term substance use. It's really a risk factor for attempts and completions. I guess I tend to be a little careful about suicidal ideation as a proxy for much. I'm not a I'm a big anti black box warning and SSRI person. That I think that warning by the FDA was totally misguided, and that the data that they cited in it doesn't even really support it, because if you look at on spontaneous reporting of the adverse events, you see a signal towards increased reporting of suicidal ideation, but you don't see it on the structured rating scales of depression in these trials. And it's suggesting that the method that you're querying for adverse events in these trials may be leading to the signal. So lots of kids have suicidal ideation. They don't talk about it spontaneously. So if you're specifically inquiring for it, you're likely to see it and any medicine that causes any side effect is going to trigger more serious, more systematic assessment of adverse events, including suicidality. And if you ask specifically about it, you're more likely to get a positive answer. And so I really don't see sort of suicidal ideation is a major thing I worry about. I would say that I think in the US, people don't monitor stimulants closely enough at the beginning. I think part of it's related to how you have to prescribe the medicines, and that insurance companies will only fill it monthly. And probably the best way to do it, and the way I like to do it, is seeing the kids weekly or even every few days to up titrate the dose and to monitor the side effects at the beginning. And I think that's one of the problems and why community prescribers are less effective at dosing stimulants than the medication management condition in MTA, is because you could be changing the dose of the stimulant much faster and managing the side effects more aggressively, and seeing kids for very frequently early on and then not very often. But the way the controlled substances work, you have to see them monthly in the US no matter what, and so it extends it. And I'd say in terms of suicidal ideation, other risk of the medicines is just seeing them quickly and having a open communication about symptoms and side effects, and just to tell the parents to report side effects. There are a lot of simple solutions to them.
Wonderful, Michael. Wonderful. I will ask a question from the audience regarding the comorbidity between ADHD and substance use disorders. What we treat first? Like, is there a step based? I don't know. You know.
I guess there are a few things to say. So it's not an easy clinical question that doesn't have an obvious answer. I don't think you can always treat one or the other. I think it's clear that having bad ADHD symptoms could impair your ability to come off substances, and that's a significant factor. The other significant factor, at least in the US, is you can take the stimulant medication, divert it, and use it to buy other substances. And so it may, in prescribing the medicines, you may be increasing potential abuse. I tend to like to, this is not rocket science. When I'm seeing these patients, I don't rule out the use of stimulants in patients with significant comorbid substance abuse problems. I tend to monitor the comorbid substance use closely, tend to try to treat as much as possible the comorbidities, opiate use, cocaine. But I think it's a tough tightrope to rope. walk. And I think completely not prescribing stimulants to adults with substance use disorders is the wrong decision. And I think the opposite, not taking into account, is clearly wrong. And it's coming up with some structure that maximizes the potential benefit and minimizes the potential risks associated with it is sort of the big thing. But it's a difficult problem.
Sure. A last question from our audience. Professor Bloch, regarding risks versus benefits of suspending, interrupting a stimulant in children with ADHD, is there any redundant evidence in literature or something that you can say for us?
So I'm not, Guilherme may be a better answer to this, so hopefully he has a better answer to this than I do. In terms of stimulant holidays, I guess it depends on the child and the risks associated with not taking stimulants. I think you can show that there are some long-term side effects of stimulants that are related to total dose burden, and there's a good chance you could decrease some of those by taking a holiday of the stimulant over the summer in terms of decreased height or over the weekends. That being said, you also have this data that shows that when you're on stimulants, you're less likely to get into accidents or reduces emotional impulsivity. And I think for the vast majority of patients, probably those more unappreciated risks of ADHD are probably a better thing. I can't say that I don't have any patients that go on like stimulant holidays. So like I have a kid now who's has terrible inattention in school, but doesn't really have any hyperactivity and impulsivity. And so like, and the parents are very worried about his height. So like, what's the point of keeping him on the ADHD medicine over the summer if he's not really having significant impulsivity and hyperactivity symptoms? So there's a rare occasion where I'm like, sure, it doesn't make a difference. But I think by and large, I tend to keep the kids on the medicine. I think that I don't think parents fully appreciate all the effects that ADHD has on their children. Usually it's attributed just to getting in trouble and having trouble paying attention in school. And there's a lot of this more subtle accident proneness, trouble with organization, emotional impulsivity that's not really appreciated as much, that I think goes along with it, that's often well controlled with the medicines. I don't know. I would want to know what Guilherme has to say, if he has anything to add to it, because he's more of an expert than I am in this.
Yes, Professor Guilherme, do you have anything to say about that?
I see this issue, Michael, as you do. We have to understand that ADHD is not a classroom-related disorder. ADHD is a disorder that affects every aspect of the children and adults' life. So we have increased risk of mortality in children. Accidents is the major cause, and we have good evidence showing that stimulants reduce the risk of accidents. So we have this. We need to have this more broad perspective of ADHD and how it affects not only inattention during class, but also, as you mentioned, emotion dysregulation, anxiety, or risk of accidents, risk of impairment on social interactions because of impulsivity or even inattention. So having this broad perspective, of course, we will decide on a very individual level what's best for that patient.
Perfect.
Yeah, I told you he'd have a better answer.
I'm just echoing your answer.
Well, do you have any other comments, Professor Michael or Professor Guilherme? Or we can end this talk.
I just wanted to thank everyone for inviting me and really the great collaborations we've had over the years and all the excellent research that people are doing in Brazil and the very few I'm fortunate enough to get in my lab.
And vice versa, Michael. Thank you for all your investment in our department and institution. Thanks a lot.
Hopefully I can get down there soon.
Sure.
Yeah, we
Yes.
are ready
Let's work
for
on
that,
that.
Michael.
Okay.
Thank you.
Thank you so much, everyone. So we can end this talk, this wonderful talk with Professor Michael and Professor Guilherme. So see you next week. Bye-bye.
Thank you. Thank you, Guilherme. Thank you.
Thank you,
Howard.
Michael.
Sure. Take care. It's nice seeing you, even if
Nice
virtually,
seeing you
hopefully
too.
in person soon.
So great. Hopefully soon.
Yep.
It's
Take
nice
care.
to know that you are on sabbatical next year.
Yes, I'm looking forward to it.
I imagine that.
Take care.
You too. Take
Bye.
care. Bye.